Top Med Talk.
Nick Geriatrician here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
So it's now time for questions. I might point out there are two roving microphones down the back there, so you can still submit your questions online and I will present them, or you can just put your hand up and we'll come to you. The one question that really stood out, I might start off with this. Having a vast range in frailty tools makes comparing patient groups almost impossible. There is a need for consensus. How are we going to achieve this? So I guess the question is, we all know that frailty, I think we've come to that agreement, should be tested for and discussed in pre-admission clinics. But what does the committee feel here might be the best tool to go forward? David was suggesting that the CFS is getting the Guernsey, but what do you think?
Well, the clinical frailty, is this on? The clinical frailty scale, has a lot of strengths, but it was originally intended to be a screening test. And a lot of people are sort of clumping around the 5-6 level on that. And, I personally think that the frailty index has a lot of strengths too, because it's more granular, it's more precise, but it's always been criticised for being too time-consuming. So if we could generate a frailty index from routinely collected information, which is surely not beyond our ability in terms of our technical expertise and the amount of data that is collected for patients when they come into hospital now, that's potentially the way forward. But people do feel very strongly about different frailty tools. It's going to be difficult to reach consensus. But I've been developing a frailty index that can be derived from a nurse-administered assessment instrument. So nurses are really key to that first-line assessment of patients, and they need to collect a lot of this data, and we can simply code it as deficits and press a button and a frailty index comes out. So I'm quite excited about the opportunities that will provide.
I might ask Bobbie Jean, I've noticed that the frail scale came up in one of your slides, and there seems to be a push. A lot of the literature coming out of the US seems to be using the Linda Fried phenotype model as the basis of the research. Do you want to comment on how that's going for you in the US compared to, say, Ruth's suggestion maybe for the frailty index as an alternative?
I think the Linda Fried index was developed, and her work was in non-surgical patients, obviously, and it was administered typically by, skilled geriatricians, and it takes quite a bit of time. So I think everyone's been trying to extract out the key points from that, that perhaps can still maintain relatively good sensitivity and specificity, but also looking at it from the perspective of the surgical patient and how that, it probably differs. And I think generally people are really focusing in on that functional piece, just activities of daily living and, how the anaerobic, aerobic capacity of patients. Because the other data from surgical studies suggest that is such a strong predictor. And then I think the important part, too, is adding in that cognitive piece, which is, technically not part of the frailty, but they often go hand in hand. The frail patient also is cognitively at risk and have cognitive impairment, because that also factors in so much, not just only predicting the post-op delirium, but also predicting how well patients will be able to help take care of themselves or engage in that post-operative piece and care that is so important. So I think there's a lot of initiatives, going around right now, trying to figure out what is the best tool. I think it has to be pretty straightforward, fairly easy to apply. I think, having nurses and, like in our situation, our medical assistants able to do it and not requiring a skilled physician to administer it. Sometimes, we look for, sometimes better is the enemy of good enough. We should maybe start with something, and something that we can use, as opposed to trying to figure out what is the ideal tool and then start gathering data.
David?
I guess being bookended by geriatricians, I've got questions for you guys. The thing that I said is the CFS Clinical Frailty Scale is a screening tool. The question is, once you've screened, what do you do then? Given that the gold standard is comprehensive geriatric assessment by a specialist geriatrician. So there is, do we just screen and then make a plan? Because when you consider the amount of time and effort that goes into the other components of a patient's operation, I was very mindful of this. I have been involved with the Medicare review on the Urology Clinical Committee. There was a lot of talk about multidisciplinary teams and risk and radiotherapy versus surgery for prostatectomy. But there was no discussion about all the other factors with the patient. It was all about their prostate cancer. And there was no element of this. So what I wonder is, the argument, as I see it, is we're putting a lot of effort into your disease, but not into the rest of you. And should we, in fact, be looking more at a model which is to screen, and then if they screen into the frail group, they then are considered further by specialists in geriatric medicine?
Ruth, do you want to comment?
Yeah, I think that's the model that we're trying to set up, because many patients, surgery, we've spoken about this many times, David, that surgery was sort of set up based on the procedure originally, and it was thought that everyone would have this smooth throughput, and some patients who are younger and fitter can be accommodated in that pathway, but others need a different approach. And comprehensive geriatric assessment, I was talking about this before we came in, isn't just assessment, it's assessment and management. And the management involves liaison with the multidisciplinary team, optimization of polypharmacy. There's good evidence that CGA can improve outcomes for frailer older people. So that's what we should be aiming for.
So I think Jeremy actually asked a question which kind of extends on this. So we've looked at you presented some of the bundles as a response to prehabilitation as an agenda, and frailty if it's picked up on the scale. So are we getting ahead of ourselves? Are we studying the effectiveness of the bundles before we actually know the effectiveness of the individual components in the bundle? And I guess the corollary to that is, which of these interventions that we've talked about this morning really have the biggest return? Which one should we be concentrating on? So, for example, nutrition versus exercise versus...
Yeah, I wouldn't be in favour of dissecting it out. It's a complex intervention in response to a complex problem. And, for example, people have tried to think about management of stroke and trying to tease out which component of stroke management is effective, and they can't really do that, because you can't take away the stroke consultant from the environment, from the multidisciplinary team. It all has to be done. Some geriatricians I speak to are very opposed to frailty as a label for people, and worry that it's going to prevent them from having certain interventions. And they also worry that it's not telling you where the frailty index, for example, if you have a high frailty index, it doesn't tell you where the deficits are. But a high frailty index should just be the start of thought processes about a patient. And then you see, if a frailty index is triggered as being high, then the geriatrician will start thinking about where those deficits are. So I don't see a problem in having a simple tool at the outset that can then be used for more complex decision making.
Ming, from a clinical trials point of view, I think the important thing to remember is that when you do a clinical trial, you've got equipoise. I mean, yes, when you go into any trial, you think, look, this is the likely outcome. And the more important thing about the bundle is if it doesn't work. So you put the whole lot together, all the best possible things put together, and if you show it doesn't work, then you move on and say, actually, this is not effective. And so I agree in total with what Ruth's saying. But the counter is, by putting them all together, you say, look, it doesn't work as a bundle, it won't work as individual bits, so don't even think about it, let's go in another direction. Okay.
This is a question about how to engage the patient. So education may not be enough to motivate. Is there any further evidence on using additional interventions, such as motivational interview techniques, to improve engagement when you've told the patient that they are frail?
So I'm not aware of any large studies or trials or publications showing that there are tools that you can use to do that, to motivate patients or to get them engaged. I think there's, extrapolating from sort of just shared decision making, I think there's tools that you can use to get the patient engaged better about their conversations, about understanding their risk, helping them make decisions. And so we have that interest in seeing whether we can develop similar sort of ways to identify those patients who aren't engaged and then to use certain tools to actually get them better engaged. I think a lot of it is that often frail and elderly patients particularly do suffer from depression. And obviously they also suffer from some cognitive impairments. So how much we can intervene will depend, I guess, on how reversible some of those things are. But I think, if we can treat their depression, for example, then improve their engagement that way, it makes sense that it would be effective. But are you aware of any perioperative attempts already at doing that?
No, I'm not actually.
So this is a question about prehabilitation. Are there any studies evaluating cost effectiveness in prehabilitation? It's difficult to persuade our executives to fund the extra resources for the ideal model that is effective.
I'll answer that one. As far as I know, no, in part because the culture of really looking at cost effectiveness for interventions in clinical trials has only just really emerged in perioperative research, I think, and in clinical trials generally. And I think as we move towards larger and stronger clinical trials, there will be integrated, particularly bundles of care trials, there will be integrated health economics to try and answer exactly those questions so we can deal with administrative overlords.
Okay, there's a question at the back there.
Yeah, hello. Peter Seal from Melbourne, anaesthetist and intensive care specialist. Thanks to all the speakers, great talks. Dave Storey, got a question for you, and it's simple. Forget the 6-minute test. What about the get up out of a chair and walk 5 metre test? My 92-year-old mother on your Rockwood scale would be moderately to severe, so between a 6 and a 7. So she doesn't do too well on that 5 metre test.
So I guess I'd rather ask Ruth. I'm aware that there are other straightforward tests. I mean, it's if you like a physical version of asking about activities of daily living. Ruth, what are your thoughts about things like the up and go test?
Yeah, the timed get up and go is a great little test. It incorporates balance, mobility, and it's integrated into some frailty tools. The Edmonton Frailty Scale uses it a lot, and it does give you a reflection of somebody's frailty status. I think it's a good test. But
again, it's probably more a screening. It's not a diagnostic tool; it's a screening tool. So the question is, if they fail the up and go, what do you do next? And my answer would be that's when you then go and consult our geriatrician experts.
So this is a question from a surgeon, so I might try to get it in there. Okay, I'm convinced about prehabilitation, but how do we get the clinic running and paid for?
It comes back to the question earlier. You've got to convince the dark side that it's cost effective.
So how do you engage the dark side, David?
I think one of the really important things in this is also, that we have, particularly, we're lucky in Australia and New Zealand, is we can look more broadly. Unfortunately, sometimes hospitals really drill down and micromanage the finances. But to my mind, part of it is convincing government through appropriate evidence that, in terms of patient journey, public health, value, and, to a certain degree, the workforce, that we're doing the right things for patients by doing these things. I think that is the key. If we can convince, the various departments of health and, the government that this is the way to go, that's the way to win, because they will then say to the hospital administrators, we expect you to be doing this. So ultimately you would want to see the Commission on Safety and Quality in Healthcare saying, are you implementing the prehabilitation bundle? And they get a big tick if they are, and they get a big cross if they're not, and all the administrators are upset.
Okay. So,
another thing to do is realize that, you can take baby steps, and there's even home-based programs where patients can even have apps on their phone, and, they have to walk a certain amount every day. They have to report in that they do a certain amount of things. And then, focusing on those other things other than aerobic prehabilitation, which is, the smoking cessation, the anemia management, the comorbid optimization, getting the geriatrician involved. So I think those are, individual components that you can do that doesn't require necessarily a sort of, focused program, But I think another place to start is engage your physical therapy departments, because physical therapists are the ones who are doing the rehab, and you can get those people involved in doing similar kind of things just before the surgery. And your geriatricians, which, often are also much more keen and engaged in these kinds of interventions with patients ahead of time.
Got a question on the floor?
Yeah, thanks. Two kind of comments, kind of questions. One to that second one. I think it's interesting that we're talking about implementing something that you've really shown a trial with 52 people in it as preliminary evidence and ongoing trials that will have cost effectiveness. We shouldn't be implementing those things because they're an opportunity cost for things that we know already work. We know ERAS principles work and haven't been adequately implemented. We know delirium prevention programs work and haven't been adequately implemented. So let's do the things that there is really good evidence for first while we do the trials for the other ones. The second comment would be just about the data, Bobbie Jean, that you showed about the really interesting study about frailty screening reducing mortality, published in JAMA. And I'd just like to introduce a caveat about that, because they didn't measure mortality, they measured post-operative mortality. They reduced operations very substantially, so there was different decision making, and the mortality in the patients who didn't have an operation, who were frailer, was not measured. So yes, the surgeons felt better that less of their patients died, but it's different to less population mortality. So I think we just have to be cautious that it doesn't necessarily mean there was less mortality.
But I think that's important, because again, perhaps they helped to identify patients who are the futility of operations.
Perhaps, but because they didn't measure whether there was more suffering or more cost, or less suffering or less cost. So I think we just have to be really cautious about. So then it might have been. I think futility is really important to discuss, and maybe they were the right decisions, but without knowing what the outcomes were for that other group, in terms not just of mortality, but in terms of suffering and cost. So sometimes not having an operation entails more suffering and cost than having an operation.
That's absolutely true. Every time you make a decision to not do something, that's an active decision to take another path, and even if there's nothing is done. But I think that we know from other situations that over the last 50 years, numbers of surgeries that are done has markedly just exploded, and that many surgeries have shown to have no utility for patients, even those who aren't frail. And I jokingly say, I don't know how many orthopedists are in the audience, but I often say that if an orthopedist can do something through a scope, it's not going to help you. So, I do think that we've just gotten to, in this very escalated kind of, situation where surgery is the answer to everything. And I think we know it's not, and particularly in those patients who are at the highest risk. So I agree that the details are in that study. I don't have time to go into the details of whether just frailty screening, help those ones who are just having. But if it identifies patients who shouldn't have surgery, if you're going to be 30% chance of dying a year after you have a lumpectomy, should you have had a lumpectomy, even if it didn't contribute to your death? It didn't, likely improve that 1 year of your life that was left.
Can I say something? Controversy alert. What is the randomised trial demonstrates the benefit of ERAS? Did I just not hear, yes, we know it definitely works?
So there are a number of
Which trial?
And
which trial?
There are, but there's meta-analysis evidence.
Yeah, I know, but which randomised trial? There are no large randomised trials of ERAS.
True, but there's meta-analysis.
I am, in fact, a co-author from the New England Journal of a paper that I'll present on Saturday, which suggests that one of the tenets of ERAS, which is fluid restriction, does not improve outcome and worsens outcome.
Yep.
So I just want to pump this. So I'm going to be controversial. ERAS probably has benefit. ERAS, the benefit may be just cultural shift. I know there's a big push about, you've got to do all the elements. I would argue that it may be that the number of elements you put in shows how good your hospital is at thinking about individual patients. I'm very concerned when people say that there is great evidence for ERAS. There is not. There are large, non-randomised trials. And then when we've gone and done a large randomised trial of a major component of ERAS, it was counter to the hypothesis. And we have time and time again in perioperative medicine seen things counter to the hypothesis. And the most important one I can think of immediately is tight glucose control in intensive care. Tight glucose control was killing people. And I'm very concerned, and I don't want to sound like a dogmatic pain in the arse, but I know I'm being one. yeah, but I will anyway. We need to be, and as perioperative medicine evolves, I entirely agree with you that we have this issue that we think things work and they seem intuitively obvious. But I think it is really important that particularly where we have the strengths of research in Australia and New Zealand, we pursue these questions, we answer them, and we also implement the findings of those studies.
I agree. I think we're actually on the same page.
We are, but the ERAS thing sets me off a bit.
And I'm not
Alison,
talking about individual components. I think as a bundle, in meta-analysis, it works. That is stronger evidence than prehab, but we want to jump at prehab.
Yeah.
Thank you, Alison. So we're going to go into prehabilitation. The 2 questions. What is the minimum time that the panel thinks is needed for successful prehabilitation? Most of the studies seem to be at 2 weeks. Is that enough time? Do we need to be spending more time at it?
Well, I think one issue is if we go back to one thing that probably does have, Bobbie Jean was talking about it, is iron treatment. Iron treatment is probably optimally given intravenous iron therapy, say particularly for patients undergoing colorectal cancer surgery, is probably about 2 weeks preoperatively. So there are elements, if we looked about the strongest element, I think that is probably one that would help time what you're doing. Bernard will tell you that the insightful surgeons at Peter Mac are happy to delay surgery to try and improve the overall patient well-being. And I agree, and Bernard would be the first to say there isn't strong randomised evidence, but that is their practice given their experience at the moment.
Okay, a couple of other questions. What does the panel think of weight loss as part of prehabilitation? There's a lot of talk about nutrition in malnourished patients, but obese patients have malnutrition of their own. How major of a problem is obesity and weight loss programs? How necessary are they in this setting?
Well, obesity is a huge problem for older people in terms of their causing functional limitations, but the studies haven't been done about weight loss because that takes a longer period than trying to build somebody up a bit.
Absolutely. Are there any studies showing the importance of sleep in patients?
Sorry, are there many people who are both frail and obese?
Yeah.
Yes.
Yeah. And malnourished and obese.
Yeah, and sarcopenic and obese.
Yeah.
One of the questions, actually, now that you've raised sarcopenia, is there's not been much discussion about sarcopenia and its role in the perioperative setting. Do we need to discuss it more openly? What's its relevance in terms of frailty? Would you like to comment, Ruth, maybe?
They're very closely linked to frailty. In sarcopenia, the loss of muscle mass and function and strength. Some people sort of conceptualise it as a completely separate process to frailty, but I think it's all very closely linked together in terms of ageing and degeneration and decline, and something that we might be able to do something about, if not reverse completely.
There's also another screening test that's used in aortic and colorectal cancer surgery, where with the abdominal CT that's part of the surgery, you can look at the area across the psoas muscles as an attempt to quantify sarcopenia.
2 last questions. Are there any studies showing the importance of sleep in patients and its effect on preparation for surgery? Sleep. So getting your sleep before surgery.
Actually, that's an interesting question. Sleep disturbance in the frail and elderly?
Well, there are a few reports starting to come out about how important it is, and long periods of changes in circadian rhythm are thought to have an impact on health status and frailty status in older age. But I don't know about the immediate effect and whether it can be reversed. Very important in relation to delirium, obviously.
And the final point, I don't know if it's a statement or a question, but I'll try to turn it into a question. Often I feel futile doing these assessments. And when I told my surgeon there's an 80% risk of complications and 50% mortality in a 92-year-old, they still go ahead. The attitude being, it's worth taking the risk and I can't let the patient die. So I guess the question in that is, how do we engage our surgical colleagues if we do feel that the situation is untenable? Do you have any advice on how we should be doing this?
Well, it's going to require a paradigm shift, isn't it? And the important thing is what the patient wants. And we just have to reframe the discussion around their own goals of care, and rather than surgery can be done.
I think to a certain degree, to paraphrase it, you can gang up on them a little bit. We have colleagues, so if you, in that situation, if you bring in colleagues in geriatric medicine, if you bring colleagues in intensive care medicine into the discussion and say, well, where do we think this patient's going to go? What are the goals? I think particularly if you have a goals of care, if you say to the surgeon, what do you actually want to get out of this? And say to the patient, what do they want to get out? What do the family think? I think that helps move beyond there's an operation, I must do it. And once you force the surgeon to say, where do you think this is going to go? I think that pushes the issue a bit more. And I think you can do that without being too confrontational.
Yeah. Probably do.
Sorry, my original couple of slides about the generation shift. So that the patients who are 90 now are the silent generation who would happily go along with what the surgeon told them. But I think that is going to change in the years to come.
I also want to add that piece, and I want to really focus on my talk about the after 30-day mortality, or the after 1 week mortality at 30 days. I think many surgeons that I talked to were shocked by that JAMA Surgical article that showed that 30% of patients were dead 1 year after their lumpectomy. Surgeons don't have follow-up long-term. We have no data in the United States, I don't know what's here, about how well patients do or don't do. And so I think that, again, by identifying this group of patients who are elderly, who are frail, who have limited life expectancy, regardless of whether they have surgery or not, then when surgeons start to become aware of that, I think they are having their own aha moments. Why would we put the patient through this? Why do we have the patient just, even the time they're coming to the hospital and having CT scans and follow-up and not being with their family and not enjoying, what little life they have left. And I think that's so important. It's just this idea that you're going to live forever. And all these stories about, people are 100 having joint replacements and still running marathons. But we forget that that's the 0.1% of that age group.
So, one last question from the floor.
Just as one of the few surgeons in the audience, it's Michael Cox. The way of doing it is actually to get all of your surgeons to use the Nesquik calculator routinely in their room and tick it off to say that they've actually shown them the graphics and talk to their patients about it. That's when they'll realise what their longer-term outcomes and the risks really are, and that's when they'll engage the patients.
Yeah, I agree with that. The Nesquik printout is fantastic discussion starter. I agree.
So on that note, we might stop. I'd like you to join me in thanking our speakers for an excellent presentation.
Geriatrician here. On August the 11th, 12th and 13th, the American Association of Nurse Anaesthetists will be holding their annual Congress. Top Med Talk will be coming to you with live updates from the meeting as it happens. We'll be interviewing thought leaders, academics and prominent practitioners for 3 days of discussion and debate. The opioid crisis, enhanced recovery, innovations in anaesthesia and much, much more. Guests will include the president of the AA&A, Gary Bridges, Lynn Reid and Lorraine Jordan, to name but a few. To get ahead of the curve, why not listen to some of last year's podcasts from the AA&A? Simply go to topmedtalk.com and type into the search engine AA&A. Pop that in and you will find our output from last year. In the meantime, of course, if you want to find out more, the American Association of Nurse Anaesthetists are holding their annual Congress August the 11th through till the 13th. Go to topmedtalk.com for more details. And while you're there, make sure you subscribe to Top Med Talk. And of course, you've joined us on social media. That's topmedtalk.com.